Sid O'Bryant is at the University of North Texas Health Science Center, Interim Director of the Institute on Aging and Alzheimer's Disease Research, and Associate Professor of Department of Internal Medicine. And as Carol Zernial mentioned, we had him as a guest on our radio show, Caregiver SOS on Air. He was fabulous. I guess we're going to find out how you do here, because we got a real test here. You're live and in person. Dr. O'Bryant's laboratory studies factors related to cognitive loss during the aging process, particularly Alzheimer's disease. He's known as a global leader in the area of blood-based biomarkers of Alzheimer's disease and led the international working group that recently generated the best practice guidelines for pre-analytic methods in the research area. He's generated and cross-validated a blood-based screener for Alzheimer's disease, and more recently, he has generated methods for identifying subpopulations of patients suffering from Alzheimer's disease, so targeted, personalized therapeutic approaches can be generated. And you can read more about him in the program. I don't want to take any more of his time, and we'd like you to please to welcome Dr. Sid O'Bryant.
If I can muck it up. All right, does that work? Okay, I'm a good Southern boy who has to use my hands, so if I use a microphone, it's going to end up in someone's lap. I'm going to throwing it or doing something. Okay, so there's a clicker somewhere. First of all, thank you very much for having me here. It really is a wonderful opportunity and honor to speak to you. I'm a little disappointed that I have to speak after the two speakers this morning, who are both they're prettier, smarter, and better, more articulate than me, so I will try not to let you down too much. I am going to talk to you today about advances in Alzheimer's disease research, and I promise you I will actually speak to you in a manner that you understand. I'm not going to use words that no one knows, and if I do, just throw some food at me and I'll correct myself. So I always have to make some disclosures that there are patents pending, and we've been funded from multiple organizations to do this research. I'm going to talk about a variety of different things today, and if there are questions or anything, I think you want to leave it towards the end. Okay, all right, because I'll tell people just raise your hand and shoot them out, but I don't want to get in trouble. So we're going to talk about some recent work about the blood test. I'm going to cover this new concept called endophenotypes, but I'll explain exactly what that means. So why is this important? Alzheimer's disease is, in my opinion, the single biggest problem facing the medical system today. Not just in the United States, but globally. There are over 5 million patients right now in the United States. Texas has the third largest population of Alzheimer's disease patients in the United States. So that's a lot of patients. That's nothing. What's coming, some like to term the silver tsunami. I don't know that I don't find that pejorative. I haven't figured that out yet. But then again, I'm going bald, so I won't be silver. You know, you take what you can get. Hey, you know, at least I still have a head, so, you know. It becomes more and more important when you put this in the context of the aging nature of our country and the globe. So those above the age of 85 are the fastest growing segment of the population. In the next several years, you're looking at over 14 million new individuals reaching the age of 65. Why is that important? Well, age is the biggest risk factor for Alzheimer's disease. It's the biggest risk factor for memory loss. So I'm going to take just a step aside for just a second and say I'm going to use the word dementia only because that's what the medical field says I'm supposed to use. I almost never use that word in my daily work because almost everyone that I work with is Hispanic. And dementia in the Hispanic community means crazy, and it's very rude. I've learned that clinically, and so I'm going to use it, but what I mean is the clinical definition of changes in memory, changes in thinking. That's all I mean. All right, so right now, every 69 seconds, it's estimated that someone is developing the disease. Within the next few decades, that's going to drop down to every 30 seconds. The emotional impact is immeasurable. The financial burden is astronomical. Interestingly enough, there was a recent survey that looked and showed that care, Alzheimer's and dementia care, is as expensive or more expensive as cancer and heart disease. Alzheimer's disease became the #1 fear of the elderly about 4 years ago. So this is a major issue that we have to deal with. There is the estimated annual cost of Alzheimer's disease to the United States by 2050. So what you see by these numbers is approximately anywhere between 10 and 13% of individuals above the age of 65 are suffering from Alzheimer's disease. However, when you look at it broken down by decades, what you see is advancing age is the #1 issue. With those above age 85, it's almost 50% who are suffering from the disease. That's whether they know it or not. 300,000 Texans suffering from the disease. Then there's this pre-Alzheimer's disease. Some of you may have heard of the concept of mild cognitive impairment, MCI. All that means, the thing about memory is if we wake up and our memory is drastically different, our language skills are drastically different overnight, that's not Alzheimer's disease. That's a stroke. That's a tumor. That's something that has happened to that person immediately. Alzheimer's disease is a slow process that takes a lot of time, and it develops over decades. So when you get into the pre-Alzheimer's, all this means is memory has changed, or language or something about their thinking has changed, but they still function. When you cross over into the dementia diagnosis, what that means is the person can no longer function by themselves. Someone else has to manage things for them. My wife says I'm demented already. She manages me. So here gets some interesting things. Approximately 15% of those diagnosed with MCI will convert to Alzheimer's disease every 12 months. But that's only 15%. About 15% actually, quote unquote, revert. So MCI as a prodromal pre-syndrome doesn't mean someone is slated to have Alzheimer's disease. It means they are at significant risk for the disease. I'm just going to press the wrong buttons. So it's estimated that 10 to 30% of those age 65 and above suffer from MCI. So when you combine that with Alzheimer's disease and other dementia statistics, 15 to 40% of individuals 65 and above are suffering from memory loss or some other cognitive loss. Explains Congress. Just saying. All right. So, just by base rates. So, caregiver sorts of things, and I'm going to get into the science components in a moment. But some of the things that I end up trying to address, I'm a psychologist by training, by the way. So I'm a neuropsychologist. I'm the person who does memory testing and does the diagnosis of dementia. So I wasn't trained in a lab. I was trained with people. And I'm still licensed in the state of Texas. As a psychologist, the thing that bothers me most about this disease is as follows. In life, you have one thing that's yours, and only one that cannot go away, and that's you. That's who you are, your sense of self. Everything else can go away. Alzheimer's robs people of that. I find that fundamentally wrong, which is why we do this work. But what it does to the family, the loved ones, the community, society. That's the consequences of the disease that oftentimes we don't appreciate. I sit down with patients and families, and let's be honest, the most stress suffered is by the family 90% of the time. My grandmother passed of Alzheimer's disease. My mother was a caregiver twice. She cared for her mother when she died of cancer, so she was a caregiver for her for about 3 years in their home. She passed in actually the bedroom that I grew up in. Then, within 12 months, my father's mother got diagnosed with Alzheimer's disease, and she was a caregiver for 8 years. 12 months after my second grandmother passed, my mom got diagnosed with cancer. And she went through 3 surgeries, 2 rounds of chemo. She is, by all accounts, partially cancer-free at the moment, and has been for a while. Do I think being a caregiver caused cancer? No. Do I think being a caregiver exacerbated and made it worse? Absolutely. From the basic biological effect that being a caregiver has on the person, you're at increased risk for the cold, the flu, cancer, stroke, heart attack. If you have diabetes, it's worse. If you have depression, it's worse. If you have anything, it's worse. It's like taking a 100-pound weighted vest and laying it on top of someone and saying, have a great day, and expecting them to do everything they normally do without assistance. It's unfair. Caregiver, the number one thing that I've dealt with caregivers was touched on previously, is the guilt. No one can do it like I can. I had this wonderful, wonderful patient. She was 96, and her husband was just this most amazing gentleman. He tells me the story. He says, you know, son, how long have you been married? I said, at the time we'd been married about 10 years. I said, he said, how long did you court? I said, well, 6 years. The first song in our wedding was At Last by Etta James. That's not a joke. My wife picked it out. So he tells me, he says, you want to know when I knew I was going to marry this lovely woman? Been married over 70 years or something. He said, the first moment I saw her. He said, I went in to go see my best friend, never been to his house. I saw her, and I literally walked into her room and asked her to marry me. He said, 2 years later, whatever, she finally married me. And they'd been together all that time. And he said, Dr. Brown, I can't let someone else take care of her. The week before, he had fallen trying to take care of her. Fortunately, nothing major happened. I told him, I said, what's going to happen if you fall and you hit your head next time you're trying to get her out of the tub, and both of you die because no one comes to your rescue and no one knows? Well, I guess I hadn't thought of that. Finally got him, I actually met with him about 6 times to get him to agree. Got her in a place to be taken care of because he actually did have some medical issues. And then he wanted to take her out when he was better. I called him. His daughter called me. I called him. You got to come back in. We had a nice discussion about it, and I told him, I said, no, you can't. You can't do that. Well, it's not your decision, not my decision. I said, but how are you doing? I'm good. How is your wife? She's lovely. She loves the place she's at. She's happy. They take great care of her. I spend 6 hours a day over there, and then I go home. I said, so you're healthy. She's happy. Why do you want to muck this up? He finally got over the guilt, and she was taken care of. Then I can't stress how important this is. And you have to convince, you have to convey the importance, and you have to work with your caregivers, friends, families, loved ones, that it's okay to take a day. It's okay to have some time to yourself. So now I'm going to get into the research. So, why a blood test for Alzheimer's disease? So, this is your brain. This is your brain on Alzheimer's disease, basically. What happens in Alzheimer's disease is the brain shrinks. Cells die. This area right here, that's memory, or at least one of your primary pieces of your brain responsible for memory. That here is this little sliver right there. That's why Alzheimer's disease hits memory systems first. There's a basic biological reason. The plaques and tangles in biology hit that area of the brain earliest. Then it spreads elsewhere. That's why later on you get other things. But very early in most patients you have a memory loss. So why is a blood test for the disease important? I'm a clinical neuropsychologist by training. I lived 1,500 miles away when my grandmother was starting to show signs of Alzheimer's disease. So I had to walk, push, kick, and drag my family through the diagnostic process because they didn't want to do it. And two, they couldn't find anyone. They couldn't find anyone to go see. They didn't know what to do. The primary care doc didn't know what to do with them. Said, I don't know what's going on. It might be Alzheimer's disease. Send you to the neurologist. Went to the neurologist, wrong neurologist. That neurologist didn't specialize in Alzheimer's disease, et cetera, et cetera, et cetera. So in my opinion, the diagnostic process is broke. It's completely broke. It's not that it's bad. It's broke. What is this current gold standard? It's a specialty clinic. Dementia specialist, physician, most of the time neurologist or geriatrician, sometimes a psychiatrist. But dementia specialist, I promise you, not all neurologists know anything about Alzheimer's disease. You do blood work. Why do you do blood work? To rule out other things. Okay? That's the point of the blood work. Brain imaging. Why do you do brain imaging? To rule out other things. There's not an MRI scan that's going to tell you you have Alzheimer's disease. Confirmation at autopsy. So the gold standard to diagnose someone is to diagnose them after they're dead. Kind of a problem, don't you think? Especially for someone like me who's a scientist that wants to prevent the disease, treat the disease. I'd like to see people pre-mortem. So you have now some really interesting and fascinating things. So there's now what's called a brain scan, an amyloid PET scan. Beta amyloid and tau, plaques and tangles. Plaques, beta amyloid, tau, tangles. That's all it is. And those are just proteins. That's all they are. They're proteins that just become abnormally formed and they clump together like glue for the plaques or the tangles, basically get embedded into the neurons and the neurons die. You can do a PET scan of that and see the plaques. We also now have PET scans to see the tangles. Has anyone well, I'm not going to ask that question. People in here have had loved ones, like myself, who have been diagnosed with cancer. Was a PET scan how they got diagnosed? No. PET scan's confirmatory diagnosis. Why is that? Do you know, did you ever see your bill for your PET scan? Yeah. Even when your insurance covers it, it's still, your stomach basically hits your toes. Because a cheap PET scan's about $5,000. And that's a cheap PET scan, by the way. I've seen bills over $20,000 for one scan. This, at a minimum, is $5,000 a pop. So obviously, not going to be used for our frontline screening purposes. Just not going to happen. The other thing is, how many PET scanners are there? Not enough to do brain scans on the 40 million Americans age 65 and above. So that's why some of us have decided we have to do something about this system. Can we create a method that can be used in primary care providers' offices regularly, that's cost effective, that's time effective, that can be that referral. It can be the reason that your primary care doc says, you know what, you need to go to this specialty clinic. You need to get a beta amyloid scan. Exactly how you get to your cardiologist, exactly how you get to your oncologist and many other specialists. Now the problem with this is when I started this work about a decade ago, was that there was about 30 years worth of science saying it wouldn't work. So, being that good Southern boy, never tell me I can't do anything. That's just a nice way to make me say I'm going to do it. So, what we think a blood test can do. How can it change practice? Well, it can be used for primary care providers to do that screening so that anyone, anytime, anywhere can walk into any clinic, get a blood draw, that blood tube can go off and get tested just like you do for your cholesterol, your glucose. Well, glucose you're doing different ways, but HbA1c. But there are other things. One of the reasons that we don't have more drugs for Alzheimer's disease is because the trials cost so much. Alzheimer's disease trials, major trials, last 2 to 3 years sometimes. Cancer trials last 3 months, 6 months. You can see the tumor shrink, or it doesn't. Alzheimer's disease is different. The trials cost so much money that the companies are very hesitant to do it. So if you can reduce the cost of the trials, you can increase the number of trials. So here's a decade's worth of work in one slide, so it's always disappointing. But it really is a decade's worth of work in one slide. So here's where we started. This summarizes a lot of work. So we started off up here. The approach that I take and that I took towards this is, do I think we can create an Alzheimer's disease blood test? Absolutely. I think we just used the wrong tools. Do I think there is a thing in your blood that tells me you have Alzheimer's disease? Absolutely not. As a matter of fact, in the cancer world, they have blood tests that will predict whether or not you're going to respond to therapies. They have blood tests that will predict whether you're going to relapse or have an additional occurrence. None of those blood tests have one protein. None of those are single markers. They're very rare things that will tell someone you have a risk for a disease. That's one thing. The BRCA genetic test, BRCA stages, BRCA mutations. BRCA stages is also an Alzheimer's thing. But there are a couple of genetic tests, but other than that, that doesn't happen. So we started off with a broad panel with the notion of, is there a profile of blood proteins that they go up, they go down? I just want to know, is there a profile of the disease? 108 markers, it was 95% accurate. Ooh, okay, so yes, there is a profile. But 108 proteins cost about $1,200 a person, so yeah, not very cost effective. So we got down to 30 proteins, 94% accurate. Okay? Here's where this should be a different color, because this is incredibly important. This is where we went to a different study. You can create whatever you want in your own study and in your own lab and in your own clinic, but if it doesn't work in a different clinic, it's not useful. So this is where we were the first ones to ever do this. We took it and went from a Texas-based group of actually there's over 1,000 people in this study now, and looked at a US-based group. And it retained, it was 90% accurate at the blood test. And that, by the way, is only 11 markers. This one, 92% accurate. It's more accurate, right? Women in here gave birth. Did you have an epidural? Yeah. How many men in here have ever had an epidural? Yeah, that's what I thought. Not many. That's how you do a CSF. It's a lumbar puncture. So people simply don't jump in line to have it. It's accurate, but yeah, they're not jumping up and down to say they have it. So most recently, this hasn't even come out yet. But actually, the journal's based out of San Antonio. 21 protein version, 98% accurate. So now what we have is a blood test that can be done in any lab, because we also changed the way the blood test is done. It's not a send-out. We've created it in a manner that anyone can buy the equipment, they can bring it so Quest, LabCorp, anyone can pick it up and run with it, and it flows. It's nice and straightforward. One of the things that I've been criticized, not me, my work, I don't take it personal. I say very facetiously. What we've been criticized for is, what is it in the blood that has anything to do with the brain? Now, your neuroscience sorts of people like to say that. I like to say they've lost their mind, because there's nothing that says that if you think that anything outside the brain doesn't influence the brain, then you really don't know the biology of the brain. There is this thing called the blood-brain barrier, but it's not as Fort Knox-ish as we like to think it is. So things cross. So we said, fine, we will cross-validate it. We'll look at it somewhere else, all right? So let's do that. So this was really fun. What we looked at is human brains, actually, and said, all right, I'm going to run these same proteins in the brain. So it's the exact same proteins that I've run in the blood. Does it predict the brain pathology? 100% accurate. So then I said, all right, what about mice? Because we have mice models of Alzheimer's disease. You know how a mouse gets Alzheimer's disease? We give it to them. So I know they have Alzheimer's disease. 100% accurate at detecting the brain pathology in the brain of mice and humans. And if I draw the blood from those mice out of their little arms, it's 100% accurate, depending on, I can go 90% with, this is with 3 markers. If I go to 5 markers, it's 100% accurate. So the blood test works incredibly well. It also predicts, this is what a brain scan of beta amyloid looks like. This is actually from our Mexican-American study. And this is someone with Alzheimer's and someone without. And it's 85% accurate at detecting brain scan positive Alzheimer's disease as well. So that got me thinking, which is a dangerous thing. If there's a blood test for Alzheimer's disease, shouldn't there be a blood test for Parkinson's or frontotemporal dementia or Down syndrome or any other neurological something? That's heresy, by the way, in the science field. We took 13 proteins. Here are the number of patients per group. This is called frontotemporal dementia, Lewy bodies dementia, Parkinson's disease, Down syndrome, Alzheimer's disease, and normal controls. 100% accurate at detecting and discriminating every single one of the groups. So there's an international initiative right now just on this, which is led out of Texas. But it includes 7 countries so far, 4 continents, I think. Specifically looking at how do we understand all of these diseases, not just one of them, because there's a lot of overlap. So this is what we've now done, and a lot of what we've done is, I said, we have a study looking at Latinos, Mexican American, the ABLE study. We've partnered with numerous people to look at how the blood test works, and this is brand new data. This has never been published. This is our Mexican American only study. Our blood test is 90% accurate at detecting Alzheimer's disease. Now, this is a community-based sample. This isn't people coming into the clinics. This is us going into the community, finding people. They come in, we recruit them, we look at them, and we're 90% accurate. So this is just like testing it in a primary care setting. It's just normal people. This is the data we had showed you. This one was fun. I just got back from Panama, and we just ran 200 samples from the first ever aging study conducted in Panama City, Panama, and they are 96% accurate at detecting Alzheimer's disease. The blood test we have can detect it in that community as well. This one is detecting that pre-Alzheimer's disease. You can see we're 93% accurate at detecting it in our Mexican American cohort. Less accurate here, but I know why that is. So we've already addressed that. So here's where we're going to take a left turn. So you'll have to follow me. So what I've been talking about so far is diagnostics. How do we fix the diagnostic process? If I can get that blood test into primary care providers' hands, that can let the docs know who to send to what specialist, who to refer. Right now, I can tell you that if I go into a primary care setting and start doing cognitive testing, 60 to 70% of those 65 and above, if I interview them, are you having changes in your memory? Yes. So how do they refer? That's the issue. That's what's going on. So the primary care docs are inundated and aren't sure what to move on. We think the blood test is a way of fixing that. Now what has happened, though, over time is there's this saying, serendipity is a scientist's best friend. Basically, I've been doing this work for so long, and when you stare at the numbers as long as I have, I don't sleep, you start seeing things. There's medications for that. But you start seeing, what I started seeing were patterns. And you would see that there seem to be subgroups of patients. So I started digging into this, and our group has done a lot in this. But So what we're going to do now is I'm going to parallel something for you. I want you to understand exactly how we treat Alzheimer's disease. So I'm going to start off with heart disease, okay? I'm going to give you, to my opinion, the best example in healthcare in terms of treating specific organ-based disease is heart disease. I don't think anyone's done better. So, heart disease, big disease, lots of things. You can break down essentially into 4 types of heart disease, okay? Big heart disease, 4 primary sorts of disease. So if I go from heart disease just to hypertensive, right? Now it goes down to different subtypes of hypertensive heart disease, which is a subtype of, right? So you break it down. So just look at atherosclerosis, breaks down to different markers of the disease. Now, do we treat at this level? Do we treat at this level? Nope. We treat down here. That's how heart disease has been so successful. They've taken the disease and understood it. They've torn it apart and understood that not everybody's heart disease is the same. Okay, so let's parallel that to brain disease. All right, there it is. That is the entire schematic. We have neurological disease, Alzheimer's, Parkinson's, multiple sclerosis, et cetera, et cetera, et cetera, and we treat right here. In what world is the brain less complicated than the heart? I mean, really? That's how you treat Alzheimer's disease. You enroll anyone with a clinical diagnosis of the disease into a clinical trial, assuming that every patient's the same. I've seen over 1,000 patients. Yeah, they're not the same. When you've seen an Alzheimer's patient, you've seen an Alzheimer's patient. There are different types of the disease, in my opinion. So here's why this scenario doesn't make sense to me. Because here, let's say Alzheimer's disease. Well, all of these things are risk factors. As a matter of fact, the original one that I had in this schematic was so big you couldn't read anything. So risk factors for Alzheimer's disease include the beta amyloid, the tau. Here I put in largely biological driven things. So things like diabetes, inflammation, oxidative stress, neurotropic dysfunction, psychiatric, head injuries, depression, poverty, poor education, sedentary lifestyle, obesity, smoking, heart disease, diabetes is the #1 midlife risk factor for late life Alzheimer's disease. All these things increase risk for the disease. Yet we still treat it as a single disease. Here's the hypothesis. Here's what many of us are trying to now start looking at. Let's tease it apart. In my opinion, the complexity of the disease is a gift to science, because that's how you beat it. You beat the disease by tearing it apart into its small components. It's a lot easier to climb a mountain one step at a time, right? So why not segregate it out and just look at those with the beta amyloid, those with tau, those with inflammation, those with et cetera, et cetera, et cetera. You can break it out into many. This is just one version of it. So what we've done over the last couple of years, we've been thinking this was there for many years. What we've started formalizing is saying that these are what we're calling endophenotypes, subgroups. If I write subgroups, it doesn't sound as catchy, so I can't get published or funded, so come on, that's a joke. We use the term endophenotypes because what that means is basically it's a biologically based way of identifying a subgroup of patients. The reason these have been selected is because they're biological systems. These are things that, right here, inflammation, that's an immune response. That's your immune response. It gets upregulated when you have a cold. Why? To fight the cold. You cut your arm, your hand swells, that's inflammation. Very simplistically. So what you have are these systems that get dysfunctional. So what we think you should be able to do is targeted clinical trials. Why not treat the biology of the disease of the patient. This is akin to enrolling someone into a diabetes trial by actually testing their glucose or their HbA1c, instead of them coming in saying, oh, by the way, I'm diabetic. Guess what? It's happening right now. First ever trial in the history of humankind that's a true prevention trial of Alzheimer's disease has now started. The A4 trial, that is by Dr. Risa Sperling. How's this trial happening and why is it absolutely so ingenious? They're doing those brain scans that you saw earlier on people without the disease, right? Not people with the disease, people who have brain scan positive plaques in their head and they're cognitively normal, which is 20% of everyone walking around above the age 65. Now, amazing trial, but it's also the most expensive study we've ever done, but because it costs about $5 grand a pop to scan about 4,000 people. And it's about a 3-year trial. So, it's the best trial we've ever done. Risa is my hero. I want to be her when I grow up. If I grow up. However, why can't we do this other ways? So, there was a really big splash, I guess it was 2 years ago, maybe 3. Suzanne Kraft, now at Wake Forest, published this work that showed that intranasal insulin improved memory in those with Alzheimer's disease. It made huge media stuff. That's now into a full phase 2, potentially phase 3 trial called the SNF trial, which is ongoing right now. What I've told her, and I'm hoping she'll give me the blood samples, is why don't we look at specifically those who have metabolic dysfunction and see whether or not it works for that subgroup of patients. But here's the one where I've spent most of my time and I'm most passionate or, I don't know, perseverative. Inflammation. Inflammation is related to Alzheimer's disease, Parkinson's disease, multiple sclerosis, traumatic brain injury, depression, basically everything, cancer. We've had 3 clinical trials to use anti-inflammatory agents to treat Alzheimer's disease. Every one of them has failed. Every one of them. Why did they fail? Well, here's why. So what we've done is created a way of taking a blood test and determining whether or not someone has dysfunction in their inflammatory system. Not one protein, because that didn't work for the blood test for Alzheimer's disease. What we took was a way of profiling inflammation as a biological system and said someone has dysfunction. They're either split into 3 groups, low, middle, and high. What that means is someone who's low in inflammation are basically immune suppressed at some level. Those who are in the middle group, which is about 70% of people, are just somewhere in the middle. Inflammation isn't really high, it's not really low. But then you have a small group, about 15%, where inflammation is through the roof. It's elevated. What happens if you take someone who is immunosuppressed and you put them on an anti-inflammatory or an immunosuppressant drug? Bad things happen. So, this is a real clinical trial. This is a failed clinical trial. This came from this right here, the Alzheimer's Disease Cooperative Studies. They did 2 Alzheimer's, 1 Alzheimer's, 1 pre-Alzheimer's. We took the blood samples from this trial. Those blood samples taken before they enrolled to the study, so it was pre-randomization. Took the blood from the patients and created a profile, split them up by low inflammation, medium inflammation, and high inflammation. So, let's look at this group. You take people who have low inflammation and you don't treat them. You leave them alone. They stay normal over 12 months. They don't really change. The bar graphs are in each group because of one person. They don't change. What happens if you take someone who has no inflammation and you put them on an anti-inflammatory drug? Normal decline in an Alzheimer's patient is somewhere around here. They decline worse. So in other words, you give them an anti-inflammatory drug and you made them worse. In the middle group, they're in the middle group. There's no difference between these 2 groups. They're just somewhere in the middle. Now, the high group. You take people who have elevated inflammation. Their inflammation is through the roof. system-wide, okay? This isn't one marker. They have true system dysfunction. And you do not treat them. They decline worse over 12 months than if you would not have treated them at all. If you'd have left them alone, they would have actually been just fine. If you treat them, however, that's the comparison. They get better. When you go from this group to this group, what happens is basically 64% of the patients in this group actually got better over 12 months. Now, it's a subgroup. It's 15% of the patients. This graph is a graph of a doomed clinical trial because adverse responders, 15%, 15%, non-responders, 70%. Every clinical trial that's designed is oversensitive to this because we don't want to treat people and make them worse. So if you have adverse responders, trials are stopped. That's those people. This is the other 70. So you've got 85% of the patients were somewhere in here and only 15% got better. So what you have is true identification of a subgroup of patients with Alzheimer's disease who you can treat with specific drugs. So if I back up and do this, and you go from brain disease, Alzheimer's disease, inflammation, treat. And you have a clinical trial that says that it works. Presented that in Copenhagen this year at the Alzheimer's International Conference. What we're working on now is, this is inflammation, as I said earlier. It's not unique to Alzheimer's disease. Beta amyloid might be. This may be very specific to Alzheimer's disease. This is not specific to Alzheimer's disease. As a matter of fact, beta amyloid's in other diseases, but this is prominent in some other diseases, particularly FTD. This and this and this and this are prominent in Parkinson's, in frontotemporal dementia, in multiple sclerosis, in et cetera, et cetera, et cetera. So what you have now is potential of subdividing patients into therapeutic groups. So one of the things that we were asked to do, and this is something that actually just happened, so it's not even, because I gave you this slide this like a week or so ago. Subsequent to that, we now have data where we've taken and looked at this pro-inflammatory, this group, this biological group, to determine, does it exist in animal models? Because the animal models are kind of how we start finding new drugs. We play around in those models that we think are the biology of the disease and we move forward. Actually, it's incredibly prevalent. As a matter of fact, when you go to these three groups, in the animal models without Alzheimer's disease, 30% are here, 70% are here. So your control mice, and 0 here, by the way, none. When you're in the Alzheimer's triple transgenic mutation Alzheimer's disease mice, where we know they have the disease because we've manipulated them genetically to have the disease, 60% here, 40% here, 0% here. So even in our animal models, which we think are, by the way, most people think that your animal models, all the animals are the same. There are no such thing as subgroups. There are very clear subgroups, even in the animal models. Well, okay, so what about, sorry I'm doing this because I couldn't update this because they already had it. It's his fault. Everything's your fault today, you know that, right? My plane's late, it's your fault. Interestingly enough, that same group, that's 15% here, that inflammatory group, it's 20% here, it's about 60% here. It is 50% here, 40% here, and it's about 70% of Down syndrome patients. So this group is it's a biological system is all it is, but it's dysfunctional across neurodegenerative diseases. So what we're trying to do now, there's a clinical trial pending where if funded, it will do this. We will enroll patients by the blood test. They get a clinical diagnosis of Alzheimer's disease, they come in, they get a blood test. If their blood test shows this profile, they go into the trial. They get an anti-inflammatory drug, determines whether or not it makes them better. Does it slow progression, does it make them better? It would be the first true targeted trial for Alzheimer's disease that has happened other than beta amyloid. So we're pretty excited about that. What it has, though, is larger implications in that it may be a way of addressing neurological issues, dementia, right? We tease apart dementias because as scientists, we like classifying things. As clinicians, we want to know what the disease is. So we put a name to it, we understand the biology of it, and we treat it. Unfortunately, in neurological diseases, that has helped us zero. We don't have effective treatments for Alzheimer's, Parkinson's, frontotemporal multiple sclerosis. We don't actually have effective treatments for any of them. But what's interesting is that when you look at the diseases together, there's a lot of commonalities. A lot of commonalities. You can find beta amyloid in Parkinson's disease. You can find tau in Parkinson's, frontotemporal, other diseases. There was this genetic mutation that was going to be the test for frontotemporal dementia. Unfortunately, it was found in Alzheimer's, Parkinson's, and multiple sclerosis. These diseases are alike, just like they are different. Okay? The blood test, when I showed you, 100% accurate, right? At discriminating amongst the diseases? It is, but there's a caveat. The profile of every disease is different with overlap. So you have inflammation that's in there, but the profile's still a little different. The profile for one disease. So there's overlap and there are differences between the diseases, but that could open up novel opportunities for treating a whole lot of things. Actually, in the airport, on the way home today, I'm meeting with a Japanese company that's testing a new drug about using this to predict treatment response in their new drug for Alzheimer's. And last week, I met with a company that wants to do it in multiple sclerosis. What is this called? Personalized medicine. This is person-centered therapy. You're treating the patient based on the biology of that patient. That's why cardiology has done so well. Does anyone know what the death rates of heart disease have had in the last 20, 30, 40, 50 years? That. What are the death rates due to cancer done in the last 20 years? That. What are the death rates due to AIDS done in the last 15 years? Gone down. Why? Because we've understood the complexity of the diseases. If you go into the science of oncology, there are people in oncology who don't even want to use the word cancer anymore. They want it to go away. Because telling someone they have cancer tells them what? Nothing. Tells you you may be dying, but that's all it tells you. What kind of cancer? Is it breast cancer? Okay, what kind of breast cancer? Cancer is treating now, they're looking at treatments that are specific to the molecular makeup of the cancer cell. We have treatment cure rates in cancer that are amazing. Heart disease, they're amazing. Why? Because we've deconstructed the disease, the diseases. There's no such thing as heart disease. Really? There's no such thing as, I love that, dyslipidemia. Okay, that means my lipids are somehow messed up. Okay, how useful is that? Go see your cardiologist, he's going to treat you very specifically. So that's where some of the newer work, and why I say, you know, I get frustrated oftentimes when I see the news, because what I see is another failed trial in Alzheimer's disease, another blah, blah, blah. And it's disheartening to the community, it's disheartening to society. And I feel it is my responsibility as a scientist to say, stop it. We're working very hard. And the science has moved on. When you see about those clinical trials, those failed clinical trials, when they go back and look at them, 30% of the patients who were in those beta amyloid drug trials didn't even have beta amyloid in the brain. Well, that's called a doomed trial. It's like treating people for diabetes who don't have diabetes, right? So, but that's not a failure. Because of that, we now have the A4 trial. We have the first ever prevention trial in human history for trying to stop this disease from ever happening in the first place. The field, and this is why oftentimes when you see, I said it, a hope for the future. The field is actually, I believe, on the verge of some amazing things. We've got potential for not only using a blood test to diagnose the disease, but we have potential for diagnosis, a blood test who will predict future onset of the disease. Well, why do I want to know I might have Alzheimer's in the future? Because now we can try to prevent it. Treating prevalent Alzheimer's disease is like treating stage 3 and 4 cancer. How successful are we when we treat stage 4 cancer? It's abysmal. It's too late. We need to treat earlier and earlier and earlier if we want to get at the disease. When I showed you that picture of the brain, yeah. Sorry, I'm just back. I'm going all over the place in this thing. Hope you don't mind. But this is a very important point. The brain doesn't regrow. That's a very fundamental phenomenon you need to understand. If I'm treating this and want it to look like that, it's impossible. It's impossible. There's nothing I can do to make that brain look like that brain ever, because I can't make the brain regenerate. Okay? Not like this, I can't. So what we want to do is treat it when it still looks like this. When there's still brain to protect. When there's still neurons and there's still a memory center left in the brain. We want to protect it. We want to keep it there and keep it robust. So what we have as a field is on the horizon. We have potentially a blood test that will be useful for the identification of patients in primary care settings. So how do you actually get a diagnosis? Well, how about we not make it last 6, 8, 10 months and cost $3,000, $4,000? Why don't we, make this a little easier on our patients? How do we enroll into clinical trials? Oh, by the way, the exact same process that you get clinically to get diagnosed is the exact same process to get enrolled into a clinical trial. Okay? So if it costs $2,000 to get a diagnosis, it costs $2,000 to get enrolled into a clinical trial. So if we can remove some of those barriers, we can expedite the process, reduce the cost of the trials, and get more trials in the pipeline. The other thing, which is a really big deal for clinical trials, where and how do you get enrolled into an Alzheimer's trial? Has anyone in here ever seen an advertisement for an Alzheimer's clinical trial? Raise your hand if you have. That's what I thought. Where do they happen? Specialty clinics. You recruit through specialty clinics. Has anyone in here actually seen maybe a diabetes trial? Hypertension trial? They're everywhere. You don't have to go to an endocrinologist to find a diabetes trial. You don't have to go to a cardiologist to find a hypertension trial. If you can have a means of primary care providers referring patients, it also increases the population pool for studies. A lot of people want to be enrolled in studies, they just don't know anything about them. So blood tests can increase access to clinical trials and reduce costs of clinical trials. But fundamentally more important is this new work, where it's a reconceptualization of the disease. I want you to walk away from here today not thinking of Alzheimer's disease. I want you to be thinking of Alzheimer's diseases. It's complex. There's more than one cause. There are a lot of things that relate to the risk for Alzheimer's disease. And until we understand the one thing that doesn't exist, in my opinion, we have to understand the complexity of the disease. When we understand that there are subgroups of the disease, just like there are subgroups of cancer, hypertension, cholesterol, everything else, if we treat it that way, we're going to treat the disease better. We're going to start actually finding improvement in patients, prevention in patients. The field is moving in this direction. It's taking a while. I can tell you that in science things move slowly, and for someone like myself that's incredibly frustrating. However, I believe that on the horizon are some wonderful things. I do this not so that my generation or myself doesn't have to face this disease. I do this so my kids don't face the disease. I have 2 daughters, 4-year-old and one turning 9. Actually, I was telling someone we have 6, 7, 9-year-olds spending the night tomorrow. And my wife's decided I'm the entertainment. I want them to look at Alzheimer's disease in textbooks. I wanted them to talk about it as, you know, yeah, it happens sometimes, but it's really not all that, and it's just pretty rare, isn't it? That's what I want them to see. And that's where I think we're headed. I think we're getting there. If you ever have the opportunity to get involved in research, please do. If you ever have the opportunity to advocate for support of science, please, please do. The annual budget for cancer research at the NIH is over $6 billion. The annual budget for heart disease research is over $5 billion. The annual research for HIV is over $4 billion. The annual research for Alzheimer's is $500 million. We spend $300 million a year on costumes for pets at Halloween. That's almost the annual budget for Alzheimer's science. We have messed up priorities, to say the least. My thought is I think we should simply take $1 billion out of the cancer budget, throw it in the Alzheimer's budget, and the cancer people will get so mad they'll just raise the money anyway. That's what's happened already. Advocate. I do all the time. Anytime I speak to anyone, I always look. You've heard from one of the physicians I actually respect most in this state early this morning. We can provide wonderful care for our patients. Without the science, we will never cure this disease, period. Okay? The only hope for beating it is the science. And in my opinion, the science is very hopeful. There's some wonderful things on the horizon. I'm going to stop there. I appreciate, I don't know if I'm running out of time, but I'm going to say. Love to. I love Q&A. So, I'll stop there and we'll have questions. Wonderful. Yes, ma'am. People are turning in cards and I'm asking, am I going to get in trouble for that? Okay, go ahead. We have a clinical trial starting in our group right now. And we have 6 clinical trials pending support. So this approach, there's a brilliant scientist who happens to be my wife, has identified, she's the brains of the operation, has identified a subgroup of patients who we think you can actually treat in pre-Alzheimer's stage with antidepressants. Because depression is one of the most common symptoms in pre-Alzheimer's disease. There's a subset of patients that we think depression is driving their disease, and we can treat them with an antidepressant. It's a subset of patients again. We've got a subset of patients, another one we're looking at to treat with an anti-inflammatory drug. We've got another one looking at treating behavioral problems with the cholesterol drug. We think there are very interesting ways to treat this disease that have simply been overlooked. So yes, we are also looking at drugs. Very, very good. And we're also looking at drugs in animals. I just started a new 3-XTG animal colony. Our group by itself does everything from animals to blood proteins to clinical treatment to clinical trials. We do everything.
Over here?
Yes, sir. Hey, how you doing?
Good.
Met you earlier.
Can you comment on the likelihood of increased financial aid for research in the political climate where we have a predominant party that's against science?
Yes. So that's a loaded question. Yeah. Although I did make the Congress comment earlier, didn't I? So, you know, The funding climate for Alzheimer's disease is an atrocity. So you can plot the funding for cancer, heart disease, and HIV to cure rates. And you can plot the amount of money versus cure for the disease. And it's directly proportional. So the more money we invested in heart disease, the death rates went down. Why? Because we did the science and figured out how to prevent the disease. Do you treat a heart attack? No, you prevent heart attacks. You prevent strokes. We haven't got there in Alzheimer's disease because we haven't invested the money. The political climate, I have significant concerns because the wonderful thing that's happened is NAPA was signed into law, National Alzheimer's Project Act. President Obama signed into law. That did, for at least a short term, add $500 million on top of the $500 million to the NIA. So that's 100 million. Sorry, 1 billion. So we're still not quite a sixth of cancer. But I don't think it's going to stay. I think it's going to go back down. I think what's happened in cancer, HIV, heart disease, there have been faces. There have been people. Magic Johnson did more for the HIV science than most people realize because he was an advocate, and he was a very powerful advocate. Alzheimer's doesn't have it. We have a few people. Seth Rogen, actually, is an actor. Some of you may know. If you don't know him, you should, especially this group, you should know who he is. He's absolutely hilarious. But he's now funding caregiver work. It's a wonderful thing he's doing. But until it becomes a societal push, like cancer was 30 years ago, and the Cure Cancer motion and the heart disease stuff, until it becomes that, we don't have a shot, and because it will bankrupt us if we don't invest in it.
Okay.
Yes, ma'am.
There is a thinking among some of the integrative medicine docs that statin drugs is very closely related to some of the dementias that we're seeing. They're thinking that the use of statin drugs for patients who are really not seriously in need of it is causing some changes in the cholesterol use in the system and affecting the brain and leading to dementia in some cases. What is your understanding of that?
So the statin drugs is a very complicated history in Alzheimer's disease because the cholesterol issues increase risk later on for Alzheimer's disease. All right, so there's an increased risk factor. So some people thought that cholesterol-lowering medications would prevent or treat, and we've tried clinical trials in that, as a matter of fact, and they failed. Whether or not they're increasing risk in some patients, the science, it's not really clear yet, and that concerns me. The thing that I think has turned out interesting is there are these new cholesterol drugs in the pipeline. They're called PKC9 inhibitors, and they're incredibly potent. These are drugs that drop cholesterol overnight. They're wonderful. They're amazing. Actually, a trial just got stopped because they thought they may cause cognitive problems in some people. Now, they figured it out. They've moved on. The drugs are wonderful. These are going to be probably the best cholesterol drugs ever to hit the market. But there may be something with that, and we have to understand it. I will tell you that a lot of people now, what they're looking at in aging, which is what Dr. Oakes really was hinting at, is relaxing a lot of medications. We know that tight control over diabetes, for example, in those 70, 80 plus can be bad. HbA1c under 8 is considered controlled in those who are over age 70. So that tight control of some of these things that we want to do in the 40-year-olds may be really bad for the brain in late life, but we just don't know enough. The biology of it is incredibly complicated. The PKC9 inhibitors lower the cholesterol in the periphery, in the heart, and in the brain. Well, cholesterol is kind of important, right? It helps transport things. It hits membranes. So it may be that what happens with a lot of our diseases, the pathology isn't necessarily pathology. It's normal biology that's gotten bad. Inflammation, for example. Inflammation is a wonderful thing. If you have no inflammation, you're immunosuppressed and you're going to die. So you want inflammation. Cholesterol, you want cholesterol. When we start getting in later life, what it may be is that too tight control of some of these things is causing biological changes that we don't fully understand. Also keep in mind that up until the last 20 years, most of the science was done on 20-year-olds and 30-year-olds. I mean, 50 years ago, all of our medical knowledge was based on medical students who were all young and white. How reflective of that is the Texas top population? So now we're trying to understand just aging. Unfortunately, one of the scientists that I work with is brilliant. He's actually just studying aging so we can understand what's normal aging. We really don't have a good conceptualization of what normal aging is. Why? Because we used to not live this long. So now we're living 80 plus years and we have to understand what that means. Beta amyloid accumulating in the brain may simply be aging. It just might be that. I don't know. I can't answer that question. And people who say they can't answer it, either they're smarter than me or they're just not realizing they don't know what they don't know. I'm perfectly happy saying, I don't know. Somewhere. Yes, ma'am.
Thank
It's a
you
beautiful
for coming.
jacket, by the way.
Thank you for coming and enlightening us
Thank
on all of the studies. And I am a family caregiver, so I'm a bit uneducated in some of these things. But my question to you was, during your studies, has anyone made any correlations as to diet, proper diet for, speaking as a Hispanic woman, we know the Hispanics are more prone to obesity and diabetes and heart disease. And so as far as I don't know if you can say prevention, but a healthy diet that can help you maintain the proper levels of beta amyloid.
So, first of all, being a family caregiver is a very difficult job. Don't qualify what you're doing to anyone. I respect you for what you do. Diet, that's a complicated question. You probably know about as much as I do. Every week it seems like something hits the news about green tea or the Mediterranean diet or curcumin or whatever and how it's going to prevent Alzheimer's disease and do this and do that and do this. So there's some research that shows that you can do a specific type of diet and you can actually change the beta amyloid levels in the brain. So there's a diet study ongoing right now in the United States to treat early Alzheimer's disease. It's actually diet and exercise combined. Dr. Laura Baker at Wake Forest is running it, and she's amazing. So diet is a very complicated question. Can I finish answering?
Oh, yeah, when you're done with that question, we have some on cards that I'll read to you.
Awesome.
And we thought you'd stay till like noon tomorrow. Is that okay?
Yeah, my wife might be upset about that.
Oh, we called.
You call her. Have at it. I don't even want to be in the room to hear what she tells you. I know what she would tell me. So diet, the best answer that I can have, that I can be 100% confident in saying is, anything that's good for your heart is good for your brain. So everything about the heart diet, it's great for your brain. I just wish that we could get that put into the Heart Association stuff. I know the Alzheimer's Association's here, and I say this to them all the time. I work with them nationally, and I say this all the time. Go tell the Heart Association to put that in their stuff, because everything that's good for the heart is good for the brain. So a heart-healthy diet, heart-healthy exercise is preventative against bad brain stuff. Now, to say this one diet thing is more important than the other, I mean, I'm friends with the guy who created the Mediterranean diet, and every time someone tries to parse it out to this type of grain and that, he just laughs. He says, how can you do that? Do you realize that every time you take a bite of anything you eat, that makes taking 10 medications look like nothing, because there are so many nutrients in your food that are going to act in your body, thousands, and it's just difficult to understand. the best science that I see so far would simply say, good for your heart, good for your brain. Yes, sir.
All right, we have a number of you put questions down, and we thank you for that, and we'll toss some of these at Dr. O'Bryant. What is your opinion of medications slowing down dementia symptoms? Are they effective?
That's what they do. So the medications slow the disease. They slow progression. There's research after research after research to show that that is the case. So I am a very big proponent of getting on the medications. Gets back to this, I say I'm a psychologist. Improve quality of life. I want patients to have as much functional capacity as they can, as long as they can. So the medications do slow the disease. They do not cure it or fundamentally change it. They just slow it.
Talking about FTD, frontal temporal dementia, any new tests or treatments that you're aware of? It's a terrible disease for those who don't know about it.
It's heart-wrenching every time I see one of those patients. There's a wonderful consortium that's dealing with the tauopathies, which is FTD is one of those, and it's actually funded largely by a Texas-based group. Right now we still have basically no treatments. It's symptomatic only, and it's devastating for any of you who've ever seen it. It's a disease that affects earlier, and the first thing it does is it changes personality. So patients go from docile and nice and friendly to aggressive, abusive, spending fortunes. It's horrific. But as of right now, they're still trying to look at it.
And when misdiagnosed as Alzheimer's, some of the treatments, medications, exacerbate FTD.
Potentially. Some of the Alzheimer's medicines shouldn't hurt, but some of the treatments maybe can. There's also other diseases, though, that the Alzheimer's medicines do make worse. And then what happens, though, is they also get put on antipsychotics,
right,
which don't help. Unfortunately, they might make them worse sometimes. Some patients, they do help, but the other thing about antipsychotics is they're black boxed in the elderly. Why? Increased risk of stroke, heart attack, and death. So the antipsychotics are useful, but they're dangerous.
What is the operational definition of accuracy in the blood tests you've talked about, and how is that confirmed?
Okay,
that came from the FDA.
I'd say that's a really, really pointed question. All right, I'm not going to get that technical with it. Whoever wrote it, pin me in the corner, and I'll go into the bioinformatics if you'd like. That was against clinical diagnosis, okay? So the gold standard was someone went through a multidisciplinary specialist clinic. So they were seen here in Texas by dementia specialists, and that was the diagnosis. The blood test is compared against that clinical diagnosis. Early stage disease. What I talked about was the overall accuracy of it, which is the weighting of sensitivity and specificity of the disease. Ours now has 90% sensitivity and specificity, which means that we can, without getting too technical, I can adjust the statistics such that I can be 90% accurate in a primary care setting where the base rate of the disease is only 10% of patients walking through the door. So it's accurate.
I heard recently from a so-called health-oriented radio program that the aluminum, and I believe it was also mercury, in flu shots cause Alzheimer's disease. Is there any truth to this? For those of you watching on television and only listening to the sound, he's smiling.
So, it kind of gets to that whole, similar to that autism, real political stuff that is still going on, by the way. I have not seen convincing evidence and data to suggest that. The other thing to say is, Alzheimer's is a cumulative thing. It happens over the course of your life. It happens over the course of time. Having, flu shots, I haven't seen any data to suggest that. And until I do, I'm going to say get a flu shot if you're 65 and above, because I don't want you dying of the flu. So, for right now, that's kind of where I stand on that one.
And thousands die of the flu every year.
Yep. And they're at risk are older and younger.
In your opinion, how accurate or effective is a mini mental status exam in determining a diagnosis.
All right, come on. Who's the healthcare provider in here that's good doing MMSEs? All right, so the MMSE, it's an atrocity, actually. It's great for a bedside clinical exam. So when I was seeing inpatients, I would use that as part of my exam. But I'm a neuropsychologist, so we do a lot more than that. The MMSE is, it's okay. It's going to be really bad at detecting really early, and it's going to be an atrocity at detecting pre. If you want a better test that doesn't take any more time, go look up what's called the Montreal Cognitive Assessment, the MoCA, and it's free. The MMSE, by the way, is now copyrighted, so if you're photocopying it and using it, I'm going to say don't do that. That's just my opinion. I do still use it in research because everybody thinks I have to, so I pay for it. But clinically, I would use the MoCA these days.
At the same MoCA at Starbucks?
No, and it doesn't taste near as good. It has more fiber in the paper, but, you know.
Where can we find information on enrolling in a clinical trial?
So I know that the Alzheimer Association is represented here. If you go to the Alzheimer's Association webpage, who's the Alzheimer's Association representative? Where are you? Come on. I know you're here. They're outside. Trial Match. That's what it is. Go to Trial Match. It is an absolutely wonderful facility. It's an online system. You can get registered. You can go into it, and it will notify you if there's a trial that you might be interested in your area. So go to Trial Match. It's the best way to find out. And if you're looking for something specific and can't find it, contact him. They'd have my email address. See, I was just prompting trial. I was supporting Trial Match, but I couldn't remember what it was.
Sure, but we need to get you on a microphone. And here comes, thank you, Pete.
All right, Trial Match is something that the Alzheimer's Association has partnered with. And what it is, you go to that website and you can sign on to be a volunteer to, be included in some of the trial matches. And you fill out and you give them certain information, and then they contact you on a regular basis when there's something going on, in your area. And you're free to decline if you don't want to. Some of it can be done, via computer. I took one through a computer. Just memory testing is what they were doing to evaluate. But they also let you know about different things that are going on. There was one where they were having a spinal tap here, and that wasn't anything I was interested in at the time. But there's a lot of different, areas that it can involve medication in some cases, in others it's, different things. But they will alert you about them once you've signed up, and then you're free to either accept taking that on. And sometimes it may not be local. The one that I took with memory testing was through the University of Berkeley in California. And it was all computer for like 3 months. But it's very interesting. And as I said, it's a great opportunity because so many times we don't think about it. When you pick up that bottle of Allegro or your tranquilizer or whatever, how did it get from there into your hand? And it involves people, willing to, try the placebo or the medication. So, but absolutely, it's an amazing program.
Thank you.
And you can just, yes. No, there's no cost. Now, sometimes, depending on who is doing the study, they do reimburse you to some extent. So it just depends on what trial you get involved with.
Thank you. Appreciate it. Thank you very much. Just a couple more questions. You okay? What time's your flight?
I don't think it's till like 2, so I don't get out of
cool.
Check in.
All right.
Oh, wait a minute. It's in 45 minutes.
Yeah. Can someone have both MS and Alzheimer's disease?
Yes. You can have multiple diseases. Multiple sclerosis and Alzheimer's are less common. But you can have, for example, about 20% of Parkinson's patients have Alzheimer's disease, and vice versa. 20% of Alzheimer's have Parkinson's disease. That comorbid thing makes things really difficult. Bless you, by the way. So having more than one of these diseases is definitely possible.
What about someone who no longer has active MS lesions?
So the pathologies of the disease overlap, but they're not exactly the same. So yes, and I have seen patients before who unfortunately had MS early in life, and then later in life they developed Alzheimer's, and unfair.
Last question. You're doing well on your oral exam. We appreciate it.
Thank you.
You'll get that degree pretty soon now.
One day. I'll call my parents. They'll be happy.
And proud.
And proud.
As you mentioned at the outset, you're using dementia and Alzheimer's disease somewhat interchangeably, but I understand all dementias are not Alzheimer's and all Alzheimer's are not dementia.
So the term dementia, all it means is change in thinking. That's it. That's the umbrella, okay? Beneath that umbrella, it's like that image that I showed up here. I'll get there. Give me just a second. Right there. So just take that as if I said this is dementia. Alzheimer's would be here. You could have Parkinson's due to dementia, dementia due to Lewy bodies, frontal temporal dementia. You can have dementia due to traumatic brain injury, the chronic traumatic encephalitis with CTE, which is so big right now because of head injuries in football players. But absolutely correct. The reason why they get lumped together oftentimes is that Alzheimer's disease is anywhere between 50 and 80% of all dementias. So it is by far the most prevalent dementia. So oftentimes you'll hear people use them interchangeably, but they're not the same thing. As a matter of fact, the new diagnostic manual that's come out, the DSM-5, doesn't use the word dementia in it anymore.
Can you not pop stem cells into that shrunken little brain and regrow it?
Unfortunately, because of the types of neurons, no. We've tried that in Parkinson's disease, and we try to get into the substantia nigra and allow the new neurons to grow. Unfortunately, something's still killing the cells, and we haven't figured it out as a science. In Alzheimer's disease, it would almost be akin to someone cutting off their arm and you growing it back. Because what you'd be doing is replacing an entire system in the brain, the hippocampal system. I do, at some point, hope we can get there. We're not even close to that right now. We can take stem cells out of your teeth, you can do skin biopsy. There's lots of ways to grow stem cells, most of which is not by what the media says it is, and turn them into neurons, but growing them into fully functional hippocampal, different, and keep in mind that that's a memory system that develops over time. So even if we can, you may not have the right connections to actually be able to resource and use your memories.
Thank you very much. This is wonderful.
I'll come to you.
Thank you.
Thank you.